Hello, everyone. Thanks for coming along this afternoon. I'm going to wait a couple of minutes before we get started, just in case anyone's jumping online a little bit late, but we will get started quite soon because I want to keep to time. Hello, Janine. Good to see some familiar faces, or some familiar names, rather. How's the sound for everyone? Hi, Vanessa. Can't hear me. Working fine for Jack. It might be on the other end. Hi, Emma. Excellent. If you do have issues with sound, it might be worth logging out and logging back in again. Okay, so I'll get moving now. We might have a couple of other people join us along the way. So thanks for coming along, and today I'm going to be talking about engaging people in online therapy, as the name of the talk suggests. What I want to say before we get started is that this is aimed at a lot of people who have may have some experience in working online, and I think a lot of us do after this year, but also from a lot of different clinical backgrounds, a lot of different disciplines, and a lot of different clinical areas within those disciplines. So the approach I'll take is to go through a set of principles, really. I want to explore the principles with you, and then take a case example of how that might look. And the idea is that you would hopefully be able to apply those principles to any number of different clients and any number of different situations when you're working online, to be able to have a little toolbox, a little kind of framework that you can work in to make sure that people can engage with you, continue to engage online, whether you're doing solely on online work, or whether it's just a part of what you're doing with that particular client. So let's get started. I'm Ed. I know some of the people who are I can see online at the moment, but for those of you who I haven't met or talked to before, I'm a speech pathologist, and I've been working in rural Australia for the last 10 years or so. And in the last probably 7 years, there's been an increasing amount of my work that's gone online. So I tend to do a lot of this stuff now. Although I don't do wholly clinical work anymore, I run UMBO with a whole group of fantastic people who try to get more services to people who don't have a lot of therapy options locally. So UMBO is a social enterprise, and at the moment we're providing occupational therapy and speech pathology to people of all ages, but we'll focus mainly, because of our example, on younger people and families today. I will talk a lot about rural stuff. It's not necessarily targeted at rural people. That's just my background. But it is probably quite meaningful to rural people to know about that lack of connection, but it's also relevant really to a lot of metro people now because of what's happened in 2020 and the way that we're starting to engage more with digital technology to support people. And in many cases, it's becoming a preference for families or clients or patients to engage this way, even if they can access a good quality allied health service in person as well. I want to get through those principles, as I mentioned. So some really concrete and practical ways of figuring out, is my person engaging? Are they not? And how can I increase that? And I'm going to do that through a specific kind of coaching framework that some of you may have been hearing a bit more about lately. It's becoming much more common, which is fantastic. And that'll include strategies to help improve your relationships with them, or ideas through the case example that we talk about, and as a result of that, to get better therapy outcomes and a bit more confidence. A lot of people who I've spoken with in the last 8 months or so have raised confidence as the major issue for the barrier for them to get good results and to feel really engaged themselves with online therapy. So these are the principles that I've used, and where these come from is I haven't plucked them from thin air. What I've done is I'm coming towards the end of a PhD thesis, hopefully to be finalised in the next couple of months. And basically, through that work, I examined the experiences of people in rural and remote areas who had difficulty accessing therapy before, and what the important things were in order to bridge that gap, what they wanted from therapy, and then use some of those principles to do a series of kind of 12 to 18 month long case studies with a number of people, number of families who did all their therapy online. I did meet them in person, but all the therapy, all the relationship building outside of that initial meeting was done online. So this data is coming from about 2018, and hasn't been published yet because I'm lazy and working with Umbo too much, but hopefully I'll be able to put it in a journal somewhere at some stage. So the first principle that we found worked with our clients was that we prioritize relationships before the intervention. So if we think about someone who we do therapy with, then they are doing, say, speech therapy, OT, whatever it is, as a very small part of their life. We're exposed to a very small part of their life, and we're not often exposed to the greater family group, friends, support networks, if they're adults, work colleagues, people in the community. And it means that we miss out on perhaps some of the bigger picture goals that person might have, and the things that are more meaningful to them in their experience. So that was the first thing that families told me. And so for the fans of Middle English literature out there, the great quote from John Donne was, "No man is an island." So we're all connected together, and we need to recognise that when we're working with our people as well. The next thing, don't rush into intervention. There's I guess we're trained as allied health professionals to jump in and try to fix things. That's what we learn to do. We learn to go in and see what's wrong and start working on it straight away. But one of the things that we saw from these studies was that families really appreciate getting to know people before sharing their innermost thoughts, issues, problems, desires. And so if we're starting to work with people and rushing into an intervention based on that really surface level knowledge that we have of a particular person or family group, then we're working on things that aren't as meaningful to them as they could be. That's going to lead to less engagement and therapy outcomes that may be good, but they're not going to be as relevant for that family. And thirdly, as part of this first principle, that quality of life, which is what we do as allied health, we work to, we're not doctors and we're not nurses, we work on quality of life. We're the glue between the three kind of elements of health, and I think a connection more to community and to social life than we are to health, really. So basically we want to think about, prioritizing finding out about what is bringing this person a good quality of life, rather than perhaps focusing on a certain skill in our intervention. So how does that skill relate to a bigger picture of that person's life? Are we just working on making a clear R sound, or are we working on using particular keywords with R in them that someone can use to order their lunch at school, or to be able to participate more actively with their friendship group? The second, going on from the first principle, these are a few more examples from the literature about why this stuff matters. So it's people in Howland's study and in mine, they told me that it's really difficult to communicate with health professionals. And one of the things that makes it difficult as well is the fact that you might get assigned someone for 6 weeks and then you change to another person. Well, that person leaves the service, and it's really difficult to get back into that groove of sharing all that is your life with someone who you've just met. So imagine kind of going to a counsellor and having one session with one person, the next session with the other, and jumping back and forth. That'd be really difficult to be able to make progress with and find a kind of coherence to what you're doing. So that's really important to people. It's also really important for people, the tech stuff, that it gives them options. It gives them options to not have to be in a therapy session with a particular person in a particular clinic, but also to be able to connect with people outside of work hours, to email, to send messages, to send data outside of those times when it's more convenient. And it's more meaningful as well. So if you're just focusing on that 9 to 5 and working then, and the goal is outside that 9 to 5, then that's tricky for people to really show you what's happening. If there's difficulty with a mealtime routine at dinner, you can't observe that between 9 to 5 because dinner's happening at 5:30 and 6 o'clock, and being able to go online gives you a bit more freedom to observe that more accurately. Also, families really just say it straight up. They say relationships are the most important thing about therapy. So if we're not focusing on them as therapists, then we're doing a disservice to our people. One thing down the bottom there from Caffrey that really feeds into this coaching model that I'll introduce soon is the importance of having someone there with you. So many of us will do therapy directly with a family, directly with a child, maybe at school or something like that, and we don't have a lot of support at the other end. But that's really key to being able to be a successful online practitioner and to be able to transfer skills into that environment. That's really the key to this, is capacity building at the other end. If you're just doing that half an hour a week, we know that's not going to make a difference. So we get that person at the other end. We have them supporting, sharing knowledge, and being able to implement whatever strategies and supports they are at the other end during the week when we're not there. So principle 2, basically what the most interesting thing, I think, almost that I found from my whole PhD was people don't care about technology. They don't care what platform you're using. They don't care if you're sitting in front of them, or if they've got a screen in front of them, or if they're talking on the phone, or if they're messaging. They really the amount of times that they mentioned it in the interviews that I did with them was just so incredibly minuscule. They didn't think about it, and they said they don't care as long as they get the results they want. They don't care. So that gives us the opportunity to connect with people with a whole different range of technologies. So don't just jump on Zoom. Don't just video call someone and plonk them in front of the screen. That's not going to work in every situation. It's not going to be productive in every situation. It will be helpful a lot of times, but it's really a matter of talking to the mother who has anxiety and she doesn't like videos, so she prefers text messages. Talking to the parent who's at work a lot of the time and can't do video calls but can do phone calls. It's talking to the family who live in a remote area with bad internet, and they go into town and they do a data dump to give you a video of what's been happening at home so you can analyze it offline. It's all those things. So keep that in mind. Don't just jump on Zoom every time you've got an online consultation or a digital consultation. Just remember that's just one little tool in your online therapy toolkit. So a bit of the literature behind this. You've got to be prepared. You have to know the platform you're using. You have to know how to use it yourself. And the other person at the other end needs to be able to support your client to be able to use it as well. That's a huge factor in the level of success that you have in your therapy. So Monique Hines and the wonderful team, our colleagues at Therapy Connect, were the ones who showed that really recently in their 2017 paper, and just really stress the importance of knowing how to use tech. And if people are scared of it, if they're reticent in using it, jump on the phone with them, say, hey, it's all right. How about we start here, and we ease into any other kind of tech usage, and get that support from that key person at the other end, a therapy assistant, a teacher, a parent, whoever it is, to be able to support them through learning new technologies, or learning how to get on a video streaming platform, so that they can be more flexible in the way that you access them and support them. And Snodgrass, so this is the coaching champion. The training and coaching people really is becoming best practice now. It's still not something that we do enough as clinicians, but we know these manualized therapies that have all this great evidence behind them, and it's all coaching. Lidkin program, Westmead program, all that kind of stuff, doing keyword sign. We have to train people. We have to coach people to do this in real life situations. So having someone just plonked in front of the screen and trying to teach them, then going away, that's like going to your piano lesson once a week and not practicing in between. You're not going to be able to play Rachmaninoff very well. Principle 3, goals before assessment. So this is something that potentially a lot of you do already. I've found that it's something that I've talked about only recently because I've found that a lot of people don't do it. A lot of people kind of jump in, do the assessment, and then they create goals from the assessment. But that's fraught for a number of reasons. So basically, we're trained to assess, to intervene. So find the problem, fix the problem. But when we're talking about supporting people with a really self-directed kind of therapy, a person-centered therapy, then it's really important to be able to figure out what's important to that person before we go ahead with assessing anything. So you've got to build a relationship with them and find out what goals are meaningful to them to start off with. Don't start with the assessment, start with the connection. And then once you have the connection, then people will be more willing to talk to you about what matters to them, and you can assess that in context. A little bit old, 2008, but doing this kind of client-led approach gives people increased self-esteem. At least for these people in this study with these adults with intellectual disabilities, and it gives them the opportunity to do really fun things in context with their therapy that really engages them more than they would be otherwise. And more relevant to the case we'll talk about in a second, interventions that really focus on developmental stages, ages and stages stuff. They really have minimal effects on motor outcomes in this case, fine and gross motor outcomes. So that's a really pretty profound kind of statement that they're saying there. We really have to focus on goals that are meaningful to people, because if we're just looking at developmental stages, then our impact is going to be really limited. So this is the case that we'll talk about, and for a little bit of background, this is a case about someone who I'll call Amelia. And Amelia is not an exact case study from my PhD, but very similar in a lot of regards. I haven't used a specific case study just for privacy reasons. I've taken a couple of elements from some of my clients and a couple of elements from this other client to basically put this case example together. But probably about 80 to 90% of it is this person and the real experiences that they shared with me and that they went through. So really a meaningful example of how these principles can work, and how a coaching approach rather than a plonking in front of the screen approach is going to increase your engagement with your clients, get better goals and outcomes. So Amelia was 6 when I met her, and loved beading. She loved puzzles and unicorns as well. She had a diagnosis of autism spectrum disorder, and she had quite a severe language delay as well. She had some, she was a sensory avoider. She found it difficult sometimes to deal with quite loud environments, or to deal with new environments as well. Some of the reasons which we were still picking apart, but in my role, that wasn't as much of the detail that I went down. So sorry for the OTs, but mainly a speech type example. But there's some OT stuff in there as well, or type stuff. So her family was living in this remote town, and what we saw when we initially met with Amelia and her family was a family at their wits' end. They were exhausted. Amelia, her mum, her dad, her older brother, they found it difficult to get through every day. Basically, they had to take life one day at a time because of a number of meltdowns that Amelia was having. They didn't know why. They didn't know why she would all of a sudden start screaming, hitting, scratching, trying to run away, trying to run out the school gate, trying to run out the door at the front of home. Obviously very dangerous things for a 6-year-old to be doing, especially in that kind of heightened emotional state. So we had a big job on our hands at trying to support this family. And what we did before we jumped in and supported them was that we examined a history of how they'd engaged with a previous speech pathologist. So they'd spoken with a number of family friends and a preschool teacher who recommended that because Amelia wasn't talking as much as they might expect, that she might benefit from seeing a speech pathologist. So when a speech pathologist did come to town, what happened was that she went and visited the family, and then she went and visited Amelia at school, and she did an assessment. So assessing first and goals second. So not the approach that we're looking to do today, to engage people more. So what happened was that the speech pathologist identified a severe language delay and began to basically see that some of the concerns that were happening with the behaviours of concern at school were to do with possibly speech and language difficulties and difficulty expressing herself and understanding what was going on in class. They created goals around this and built specifically a vocab building program that they worked on at preschool. Now, this was a really good thing at preschool, and what happened was that she began to engage more with the other kids, and the ability for her to understand what was happening around her in familiar situations became better. Her teachers became a little bit more aware of the fact that she was having difficulty, so they'd slow down and they'd spend some extra time with her to try and understand what she was saying. Worked on some conversation repair strategies to be able to get through those periods of frustration. There were still meltdowns in class, though. There were still meltdowns at home, and mum and dad, although they thought this was good, she's doing better at preschool, she's not having quite as many meltdowns, but is still exhausted because this stuff is still happening at home. In the morning when we leave for preschool, she's still hitting the roof. She's completely distressed. She's screaming and scratching and hitting, and won't go out the door. So they eventually really disengaged with this service, and they found themselves almost back at square one. It was something that was difficult for me to hear as a speech pathologist, because I know I've used that approach so many times, and have racked my brain and thought, why is this happening, and what can we do about it? But we took a different approach. So basically, when I met up with the family to start the process of supporting them through this situation, we reversed that. We didn't go in with an assessment, so there was no assessment to begin with. Obviously, I was collecting information, but we weren't using any kind of standardized assessment. I wasn't of the opinion that I was going to get any super meaningful information, perhaps from the first couple of sessions. But what we were getting out of it was the parents were allowed to tell their story, and that took so much weight off their back. They were able to tell me just exactly how much sleep they lost, how worried they were about Amelia's brother, and how stressed he was, and how he didn't understand, being a little kid himself as well. So I really started to understand that this was something that affected the whole family and not just Amelia. So it basically gave us a chance to say, hey, I'm going to give you a few little tips and tricks. So we talked about using a keyword sign for help or stop. And we also talked about thinking about what was happening before these behaviours started to emerge in that particular context. And after probably 4 or 5 sessions of really talking through and well, that's probably the wrong term to use. I think the right term is listening through. So, 4 or 5 sessions, so quite, a significant amount of time for what we would typically think of as clinicians before I started talking with them about goals. So I listened, I heard them, I collected information, I gave them these little tips, and they tell me how their life was going. It didn't make an immediate impact. The keyword sign didn't work. They didn't notice what was happening before these behaviours would happen, but they were getting to meet with me on the phone once a week and just chat it out, just tell me how horrible they felt, which in turn made them feel better, thankfully, just a little bit. So before just jumping into this slide, what I did during my conversations with the parents was that I was collecting information about the routines that Amelia was going through in the morning, not just her routines, but everyone else's routines as well. I got to figure out that this was a pretty busy family. They had a bit of a disjointed routine. They didn't all leave the house at the same time together in the morning. Dad worked in town. Mum worked closer to home. And Amelia's brother went to a different primary school from the one that Amelia had just started at. So what I gained from that was that each day was a little bit different, and that was part of the stress that the family had, because they knew that on top of all those things, that Amelia usually wasn't herself in the mornings and was having these meltdowns. So I worked with the family to conduct a functional behavioural assessment on video. They sent me videos of what was happening in the morning. They would see these things happening, drag their phone out, video it, what's happening. They knew it was going to happen, so luckily they could get some footage of it, and that went into basically becoming a functional behavioural assessment and trying to figure out what were the precursors and what were the kind of outcomes and consequences of what was happening there. We also were able to, just via email, when the family was really unable to do phone calls, unable to, they were really busy, unable to do video calls, sent them through a form, the motivational assessment scale, and they came back to me with some results for that. So we got a bit of a picture, still engaging them by looking at what was meaningful to them, and doing that in a number of different media. So already this is looking really different from perhaps what you're used to, that kind of screen-to-screen interaction that we often struggle to engage people through. It's using a lot of different media to suit the clients, and it's really focusing on that relationship and the pain points for them, rather than what we perceive as a difficulty or a deficit. So this little diagram is where we went from there. So one of the things that I mentioned before about being able to engage people online is we need to be able to do things in context. And when you have someone plonked in front of the screen, instead of really engaged through a variety of media, you've got someone who is not doing things in the real context, and potentially not going to generalize those skills outside of that context. So we needed to take a coaching approach which would engage the family, because we can engage with someone who's speaking with us verbally, an adult at the other end, and we're able to get the support of a local early childhood worker who was working with the family throughout this, to be able to be there when mum and dad couldn't, so that we could talk through what was happening. So this person luckily was attached to the local preschool. So they were kind of at one end of this these horrible morning routines for Amelia. So we had parents at one end and the childhood worker at the other. So both of them really part of this, so again, no man is an island. We kind of had to look at that as really a holistic relationship-based approach. So we identified that through the motivational assessment scale, through the functional behavioural assessment, what's happening is that Amelia doesn't know where she's going every morning. She's got a brother who goes to a different school, a mum that works 3 days a week and sometimes goes in the car, sometimes doesn't, a dad who sometimes goes to work but also works at home 1 day a week, and also sometimes her brother had band practice, so sometimes they go to his primary school before they go to hers. So everything that was happening in the morning after they went through that door was really unpredictable for the next probably hour or so for Amelia. And because perhaps a combination of her language difficulties and perhaps also because of the amount of noise and action going around in the morning, she seemed really distressed about that. So we basically identified, after I spoke with the family, that they wanted to be able to get her from the front door into preschool without having those meltdowns. And we needed to figure out a way to do that. So removing those different elements that were in her way, basically, and causing her that distress. So we did this through a variety of means, and the first one was through a little workshop that we did. So we did the workshop with mum, and we did it with a teacher at preschool, and we did it with the early childhood worker as well. So we did that all in a video context, and before that, I asked them to watch a couple of YouTube videos about what we were going to learn about. So we were going to learn about routines, but we're also going to learn about why sometimes people can get overwhelmed. So that kind of flipping your lid type learning experience. So they got to understand, okay, so Amelia's getting overwhelmed because there's all these different things happening, and her routine is changing. So they had an understanding then that it would be really important to make a consistent routine for her. So how are we going to make a consistent routine? We had to basically team up with all those three people and myself as well to throw some ideas around. And we basically worked out that we couldn't control the routine all of the time. We could control it 4 days a week. We couldn't on the 5th, but that was as close as we were going to get with that. But we did plan it out together so that it was the same and that everyone knew it was the same. So again, that kind of engaging people all around the person. So we got to familiarizing everyone with a routine that would be the same between the door, getting in the car, going to Amelia's preschool first, even if her brother and her dad were in the car as well. She was still just going from the front door into the car. Might be a few different people in the car, but then she's going straight to preschool. She's getting into preschool and being rewarded with a puzzle at the other end. But how do we stop that initial kind of difficulty with the overwhelming stress that she has in the first place? So we simply by making the routine more consistent, that added value. And then we also in our workshop went on to talk about how we could use visual communication for Amelia, and how that was easier for her sometimes to understand than verbal communication. So we did that together, and in the workshop we made up a little routine board, and that's what we used. And so we had a set of images that could be shown to her each evening before bed and each morning at breakfast time, so that she knew what was going to happen next. In addition to that, because she really did love unicorns, and her mum thought that she gets distressed sometimes if she doesn't have a pet unicorn with her, then we made sure that was presented to her and in her hands right before we went out the door, so she knew she was going somewhere. This specific unicorn was the going somewhere unicorn, and she had that with her, and that gave her some comfort as well. It probably took us about 4 to 6 weeks of working through these strategies together to be able to get some really good results, but we did get there, and the family and the preschool stayed engaged throughout it because they saw little bits of progress, and we engaged through the media that they really wanted as well, on the goals that they really thought were important. So again, as I said, they found it valuable that she could say things a little bit more clearly at preschool. But when she was in that state of, oh my God, what the bloody hell is happening, and she didn't know at all what was coming next, then that strategy was not useful for her. So shifting the schedules, making sure we're available at the right time for the right goal. A couple of times I would make sure I was available for an early morning consultation, and they would be able to debrief right after they got back from the drop-off, or they'd be able to call me live at that morning, when we'd said, we leave home at 8:15, and that's when this thing's going to be happening, and I can see that live, and I can coach them through the various strategies and make sure that they're doing okay, and try to in some way reassure them that they're doing a good job. And as I say there in that slide, they really valued most of all the relationship connection. So talking about their feelings, it really, the amount of intervention I suppose we did in terms of that traditional clinical stuff was really, really minimal compared with just talking with them through a variety of different mediums, messaging, email, phone calls, whatever suited them at the time. And that allowed us to be able to continue to work really closely with them, and for them to see that we really cared about the result that we wanted to get for Amelia, and the horrible experiences the whole family was having. So they really valued the information that I gave them. So especially in the workshop that we did, once we kind of were a little bit more sure of our goal and our focus, they said that it was a little bit tricky to start with, to understand this stuff. And you've got to obviously target your audience. Some people will be great tech heads. Some people will be able to learn stuff quickly by watching videos or by reading or whatever. Some people won't. But they really felt powerful because of the knowledge that they got through doing this stuff themselves. So I mucked in there with them and worked through it, and was always there while they were practicing on WhatsApp. They'd message me, say, it's not working, what do I do? And we'd chat through it and try to figure out what was happening. So that having a lot of knowledge and practicing things at home in context, and having your therapist there doing that with you, that was huge for them. And the person who was working from the preschool now has more skills that they can use with other kids as well. And they said, hey, actually this is working really well for Amelia, but there's someone else who has a similar kind of challenge. Sorry, that's my frogs in the background. And then they're able to use that with other children as well. So a fantastic capacity building result for them. So it gives parents confidence, capacity. It gives people who are working as key workers, therapy assistants, teachers, as well, a great deal of capacity to work through problems themselves in that horrible period between getting a referral and actually getting to see a therapist. So let's revisit some of the principles, and also my biggest epiphany, I guess, since starting to work online, that engagement doesn't happen screen to screen for the most part. That's not what we're talking about. We limit ourselves when we just plonk someone, and yeah, the plonking approach in front of the screen. We can do more than that. So if we use a coaching approach, we take away the limitations of one-to-one video calls that we have at the moment. And we open up goals that are relevant in all contexts of people's lives. We just need to be able to use the relationship that we can create with people to get to that stage. And often people have a perception that it's just one-to-one videoing. So clients and families, they might have that perception as well. But what your job is to be able to show them that there are other ways as well. And it might be a matter of engaging one-to-one on video for a while, to be able to show someone potentially that that's not the best way. If that is the best way, then you can keep going on with it for that particular person. But it can show you that then you can talk with them about options for other kinds of engagement. So like we talked about, those phone calls, or doing a little coaching workshops, or sharing videos that you've recorded on YouTube, or sharing just general YouTube videos of people like them. But as well, I'd so point to their relationships over intervention. Can't stress it enough. The amount of times where just building a healthy relationship with someone has made them see their situation differently, and has in some ways gone to improving their quality of life, is just astronomical. So many people just by building a strong relationship and reassuring them, giving them confidence, allowing them to share their difficulties with you, and being vulnerable yourself, it goes a long way to improving people's quality of life in relation to that particular challenge that they're facing. Put the people over tech. Try to forget about the tech. How would you connect with your partner, your parents, your family, your friends? And how do you do it now? Do you just do Zoom calls, or do you message them on Instagram? Do you send them text messages? Do you email them? Do you engage with them on some video calls, or do you send them recordings of what you're doing? Do you Snapchat them? Really think about how you engage differently with different people, and that'll give you the confidence to do that as well with your clients, because that's how they live their lives as well. And lastly, goals over assessment. So remember that your assessment should be guided by the goals. That's how you're going to get the best results and the best engagement, because if you assess and say, hey, here's the problem, the family might just completely back away and think this person doesn't know our situation at all. So there's some thoughts from me. Like I said, very principles-based approach, and gives you a framework for starting to engage people with different technologies, different approaches for the individual, over a variety of different clinical areas as well. So I'm just having a quick look to see. I thought I had something else here. So basically, in one of the final findings of my study was that coaching is the most important element that families identified as getting them from the point that they were at to the point that they want to be at. So those traditional therapies where I would work with the child one-on-one, that's not what people are looking for now. They're looking for skills themselves to be able to use in their own time, in their own contexts. So that's an important message, I think, that we really need to listen to as allied health professionals, because we do that less often than we might. Yeah, and at the end of the day, this coaching approach is being backed by more and more evidence. So we need in more and more different clinical areas. So we need to make sure that we don't stick to the old ways because we're comfortable with them, but continue to shift and move with how our practice is evolving as we become both online practitioners, digital practitioners, and also people who are trying to build capacity more and more in people, families, schools, communities, workplaces. So I have a question here from Miranda. Thanks, Miranda. Working in different funded service models, do you consider this approach, i.e. not just telehealth, but also phone calls, regular communications, email sharing, and coaching supports are outlined in service agreements prior to starting this type of service? How important is this type of engagement and contract with the client? Really important, yeah. And definitely it's something, so some of the language there suggests you might be talking about NDIS, potentially. It's our service offerings, our service models need to catch up with this stuff. For example, Medicare, you'd have a really hard time taking this kind of approach through Medicare because it's much more medically focused, and it's find the problem, find the solution. But in the case of privately funded services or this kind of contract-based services, who might be funded by school, preschool, and NDIS as well. It really does allow for this kind of approach to work. And what I do in developing service agreements, if I have a new client, is that I will definitely discuss that with them. I'll have a detailed discussion about what kind of approaches we might take, and I usually include the potential for all of these things. I might list them in there and say, the client may wish to access services through these different methods. And so that means that, if they do want to just stick to a video call and that's going to achieve our goals, then we can do that. But if we do have these more complex situations where we really need to engage more often and we really need to engage in different ways, then we can take that option, legally speaking, through the service agreement. Yes, it was NDIS. And a question from Emma. You mentioned using a functional behavioural assessment with Amelia. What was the name of this assessment? I work with adults with behavioural challenges. Could you use this assessment tool with adults? Yeah, so basically the ABC approach, so antecedent, behaviour, and consequence. If you look that up, you'll find you'll find templates and literature and that kind of stuff online. Definitely, I mostly work with adults. This happens to be a pediatric example because that seems to be pretty popular. So I used one of my kiddie clients to use this example, but yeah, I often will use this with adults as well. So no worries, Emma. So there's a slide up on screen now, and it's got a link there to some online training offerings that we have at UMBO. Also, please follow us on social media. We'd really love to engage you, the community of allied health professionals, as much as we can, because we're all in this together. And it's a big change for us all. So we need to know how each other is coping and how we can support each other as well. So jump on your social media channels and follow us there. And also, if you have any questions for me specifically, or if you have any interest in consultations with UMBO, or need help with anything in particular, or just want to have a chat, you can send me an email down there, ed@umbo.com.au. Luckily, I've been on time today. That was the aim. So I hope this has been of use to you. The session's been recorded, so you'll be able to access this if you've signed up. And there will be a number of other webinars that we're doing in coming months next year that will kind of relate to this this topic as well. Different things like building teams, using specific examples for different clinical areas as well, how to set up your tech platform and all that kind of stuff. So if you keep a lookout on our social media channels, you'll be able to see when those are happening. So thanks very much, everyone, and I'll see you soon, hopefully.